the next session. So next session, I will start. So what I prepared for the next is about the clinical application of theranostics in nuclear medicine. So as I have already mentioned that there is a emerging interest for this radioactive drugs in the markets. And actually, Novartis, as already mentioned, has bought this AAA and Endocyte using a lot of $billion. So, and actually it is quite promising to see that these big pharmaceuticals are having interest to our field. So actually there has been a lot of other drugs, radiotherapeutic drugs in the market. And this is some summary of which are in approved or which are in the phase 3 clinical trial right now. And before the Lutathera, there has been a Zevalin or Bexar, which has been used for non-Hodgkin lymphoma treatment. However, as you know, these therapies are not well used in the clinical application right now, widely used right now. And in some part, because it is not actually introduced in some clinical guidelines, or in some part there is reason that like big pharmaceuticals does not provide, and to compete with these pharmaceuticals could be quite hard for our field. However, because recent interest from these Novartis or Bayer or other pharmaceutical groups, we now have some competitive power to have our ability in this field. So I would like to start with 3 different kinds of radiotheranostics agents which is used. First will be the neuroendocrine tumors. So it was first commented on tumors of the small intestine and coined the term carcinoid. And a neuroendocrine tumor begins in the hormone-producing cells of body's neuroendocrine system. And it's thought to arise from enterochromaffin cells in the intestine on the bronchial tree. And it has some characteristics of frequently unpredictable and unusual biological behavior, and also frequently present late after delayed diagnosis. The types of neuroendocrine tumor is actually defined by the location of its primary lesions. And most of the neuroendocrine tumors actually come up in the small intestine, which takes more than 55%. And it is actually classified by its mitotic rate or Ki-67 index as a grade 1, 2, or 3, and it has a different prognosis. And as I mentioned earlier again, these neuroendocrine tumors has some characteristic which makes it hard to diagnose or treat. So it has a heterogeneous group of tumors like carcinoid, pheochromocytoma, and as well-known pancreatic neuroendocrine tumors or other. So it has a wide variety of clinical presentations. And also it has a late presentation. Over 60% of neuroendocrine tumors are advanced at the time of diagnosis. And the median survival for patients with advanced neuroendocrine tumor is 33 months. And also it is, as it is heterogeneous group, as is different terminology and classifications are used for the drug, for this neuroendocrine tumors. So, and also this neuroendocrine tumor, as I have shown you of the Korean case, actually in worldwide, it is also increasing number of neuroendocrine tumors. And interestingly, compared to the incidence of all malignant neoplasm, the increasing rate of this incidence for neuroendocrine tumor is more higher, and which is more getting higher and higher recently. And for the diagnosis of this neuroendocrine tumors, many biomarkers are used. For evaluation of carcinoid syndrome, you can use a blood marker such as gastrin, insulin, or glucagons, and other chromogranin A and NSE can be used as a tumor biomarker. And there are also attempts using new potential biomarkers such as microRNAs or circulating tumor cells. And imaging studies are also applied for this neuroendocrine tumor evaluation and for the anatomical imaging, CT and MRI. And also in our field, we can use a functional imaging using the somatostatin analog, which is ultrasound scan, or when labeled with gallium, we can use a gallium DOTATATE PET CT. And for the final diagnosis, we use a biopsy for histology correlation and grading of the tumor. And as mentioned, the functional imaging uses the somatostatin receptor on the neuroendocrine tumor. Then what is this somatostatin receptor? Somatostatin is a somatotropin release inhibiting factor produced in the hypothalamus. And it has a multiple biologic functions by its interaction with at least 5 different G protein coupled receptors. And it has 5 types of subtypes of this receptor, 1 to 5. And in the neuroendocrine tumors, actually major subtypes are subtype 1 and 2 are highly expressed. And for the therapeutic options of the neuroendocrine tumor, we can consider, firstly, the surgery can be firstly considered. And after the surgery, there are many kinds of therapeutic options. Firstly, for the chemotherapy using FOLFOX or platinum-based chemotherapies. And also a somatostatin analog can be used as octreotide or lanreotide. And targeted therapies such as mTOR inhibitor or targeting the vascular tumor vessels using bevacizumab or sunitinib can be used. And more recently, which has got interest, is the PRRT using yttrium or lutetium labeled with somatostatin analogs. So this is the consensus guideline for the treatment of advanced local regional disease or distant metastasis of neuroendocrine tumor. And after the surgery, you can do a normally, the first-line therapy for this somatostatin neuroendocrine tumor patients are using the somatostatin analogs. But except in the high grade with grade 3, the chemotherapy can be used as a first-line therapy. However, for the second-line therapy, there is no one consensus right now, and there are many options that can be used. And also, PRRT is included in this as a second-line therapy. To further see some mechanism of these therapeutic agents for neuroendocrine tumor, we can first look for the somatostatin analog, which is used as a first-line drug. And actually, it binds to the somatostatin receptors, and after internalization, it has an effect in regulation of apoptosis in growth and proliferation of the tumor cell. And also, it has an effect for decreasing the signaling and secretion of these neuroendocrine tumor cells. So actually, it can control the disease, and also it has an effect for controlling the symptoms of the patient. Nextly, there are some some targeted therapies has been introduced in this field, which is everolimus, which is the mTOR inhibitor, and also sunitinib and bevacizumab has been introduced to regulate the vessels, the endothelial cell or pericyte of this neuroendocrine tumor, which can actually inhibit the neovascularization of this tumor. So there has been many studies regarding ongoing phase 3 studies in advanced neuroendocrine tumors, and these are some landscape of neuroendocrine tumor phase 3 clinical trials. And actually, most of these trials now have been completed and have been introduced to the clinical guidelines. And to see for the summary, it is using some different kind of drugs, such as a somatostatin analog or targeted drugs, such as sunitinib or everolimus, and for some different targets. But these different randomized controlled trial has some limitation, since as you have seen from the summary table, it is impossible to compare the outcome of one study to another. So you cannot compare the non-leucide with like chemotherapy to the targeted therapy or PRRT to the targeted therapy. And overall survival is difficult to assess since results area confounded by high crossover rate. And it is also seen that placebo indicate that these may be feasible in patients with low risk profiles. And with targeted drug, they neither achieve cure nor high objective remission rate, but they go to a stable disease state. So new agent now has been emerged, has been gather an interest, as you will be the peptide receptor radionuclide therapy, which is PRRT. And it is currently being investigated as treatment option for prostate and pancreatic cancer, and it uses a cell targeting ligand, a somatostatin analog as a ligand, and it puts a therapeutic radionuclide of yttrium or lutetium on it to get a therapeutic effect. So from the clinical trial, NETTER-1 trial showed, clinical phase 3 trial, NETTER-1, showed a high efficacy of lutetium DOTATATE for PFS and also the overall survival. So by this kind of clinical trial data, it has gotten a approval from the FDA in 2018. And what's next? So the PRRT Lutathera has now been approved by the FDA, but what kind of trials are coming next? That's what I want to introduce. So there are new randomized controlled trials and other prospective trials for the purpose of broadening the indication of this drug. And secondly, for the comparison with targeted therapy agents. And other new therapeutic strategies are under validation by this prospective clinical trials. And the attempt is about combination therapy and of selective intra-arterial injection and using alpha particles, and also there are attempts using somatostatin antagonists rather than agonists. So for the firstly, I would like to introduce a NETTER-2 clinical trial, which is ongoing right now worldwide. And also Korea is included for the NETTER-2 trial. And we we have started the enroll of the patient. So as you can see in the NETTER-2 this trial inclusion criteria, you can see it is quite similar to the NETTER-1 trial. However, it focused on more higher grade patient, which has a Ki-67 index more than 10%. And also the interesting part of design of this trial is that if you see the exclusion criteria, it excludes a patient who previously got other kinds of therapy, including interferon, evolurin targeted therapy, or chemotherapy. So actual purpose of this study is to see the efficacy, whether this lutetium dotatate, Lutathera, can be used as a first-line therapy in the grade 2 or 3 neuroendocrine tumor patients. So with the results of these kind of clinical trials, actually we can broaden the indication of the usage of the PRRT. And nextly, there is a comparison to the targeted therapy everolimus, which is named as a COMPETE trial. And it enrolls 300 patients worldwide. So the result of this trial will show what may be the more effective clinical option for the second-line therapy in the neuroendocrine tumor patients. Nextly, there are some prospective trials using a combination with PARP inhibitor with PRRT. And also there is a study of a new strategy by intra-arterial injection of this PRRT. And it has a rationale that when we give it in intra-arterial, it can give to the tumor more effectively, since the neuroendocrine tumor mostly have a lot of liver metastasis. It can deliver the PRRT more effectively, but with a low chance of toxicity for the other organs. And also there are attempts using labeling with the alpha particle and also using somatostatin antagonist. So this is one example of a alpha particle labeled therapy, and it was a first in human experience and showed a quite effectiveness for the therapy of neuroendocrine tumor patients. Nextly, I would like to move on to the prostate cancer. And actually in Korea, prostate cancer was not a frequent cancer, but nowadays it is significantly growing in men. And for worldwide, 10 or 20% of men have advanced prostate cancer at the time of diagnosis. And more than 40% eventually progress to the metastatic castration-resistant prostate cancer, which can be abbreviated as MCRPC. And this MCRPC is considered the lethal phenotype of prostate cancer and is defined as disease progression despite pharmaceutical or surgical castration. And for this MCRPC, now the standard treatment is taxane-based chemotherapy or antigen-androgen pharmaceuticals or an antibody therapy. But there are new options for this MCRPC, which we have an interest. And it is targeting this prostate-specific membrane antigen, which is PSMA. And it is mainly expressed in prostate cancer and tumor-associated neovasculature. And this PSMA is highly expressed at all stages of disease and upregulated in androgen insensitive or metastatic disease. And it is expressed on the cell surface as an integral membrane protein and not secreted or released into the circulation. And after it binds to the receptor, it is internalized So using this PSMA as a ligand, when labeling with the radiotheranostics radioisotope, we can achieve a therapeutic effect. And there has been a phase 2 clinical trial using this lutetium PSMA 617. And it evaluated the patient for the primary endpoint using 50% decrease of PSA. And it also evaluated radiographic progression or quality of life as secondary endpoints. And as you can see, it has shown quite an efficacy for the control of PSA level. And also, it has shown a minimal toxicity. However, the most frequent toxicity reported was the dry mouth, which was not allocated for grade 3 or grade 4. Only mild grade 1 and 2 were mostly reported. So now there is ongoing trial, Vision 3 trial, which is the phase 3 clinical trial of lutetium PSMA 617. And the endpoint of this trial will be evaluating the PFS and overall survival compared to the best supportive care. So after the end of this trial, we will see whether this lutetium-based therapy may be introduced to the clinical guideline of therapy of mCRPC patients and get approval. And there are also some other studies that is a comparison of this lutetium PSMA Theranostics to a standard treatment, which is the taxane-based chemotherapy. And also there are, as the lutetium DOTATATE also, it has also a combination therapy with the PARP inhibitor and also the combination with the immunotherapy. However, this lutetium-based therapy has an efficacy of near 45% of patients which has a biochemical PSA response. However, near 40% of patients do not actually respond at all because the prostate cancer patient usually has a disseminated bone metastasis. When this drug is delivered to all these disseminated lesions, it can induce a diffuse red marrow infiltration, which will induce a red marrow suppression of the marrow function. And actually, if adverse events after the lutetium PSMA test has been reported that many of grade 3 and grade 4 toxicity was actually reported for the organ system of blood and lymphatic disorders, and which is related to the suppression of the marrow function. So there has been a need for a new therapeutic agent. A new therapeutic strategy, we can reduce this kind of toxicity. And so actually there is an attempt using alpha particle, which has labeled the PSMA with actinium-225. And as you may have seen, this patient, the case of the patient that had a significant effect by this alpha therapy has shown with the lutetium therapy, this patient had no actual effect of PSA response. However, after the actinium therapy, the disease has significantly reduced. But for the application of PRRT therapy for neuroendocrine tumor and prostate cancer, there are still some concerns which need some consensus. Firstly, for the response evaluation, there are still some concerns. What kind of method we should use for evaluation of the response? Actually, most clinical trials are still using for the in case of neuroendocrine tumors, using the CT and anatomical grade. However, there are some attempts for using the functional imaging, such as a gallium DOTATATE for the evaluation. However, the concern is that the therapy, when it is not when it does not have a response, actually it can make a chance of de-differentiation of the tumor cells. And this de-differentiation of tumor cells consequently can have a lower the uptake of the gallium DOTATATE. So when you evaluate the patient with just the uptake value of this functional imaging, it can be limited to evaluate such patient. And also there are some concerns about personalized dosimetry. Now we are actually using a fixed dose for lutetium DOTATATE in Korea for the clinical trial, and also Lutathera is usually actually applied as a fixed dose. However, there are some consensus that personalized dosimetry can actually enhance the efficacy and in the same time reduce the risk. So the personalized PRT of neuroendocrine tumor is actually, there is a clinical trial to do the dosimetry and adjusting the dose. And I think the further discussion for this dosimetry actually will be discussed at December. We are planning a December meeting of Theranostics in the aspect of nuclear physics. So I would like to also welcome you all to the winter TEIN workshop, which is planned in December. So we have discussed about this lutetium DOTATATE and lutetium PSMA for neuroendocrine tumor and prostate cancer treatment. And I now would like to introduce some new future nuclear theranostic approaches, which is the fibroblast activation protein. So cancer-associated fibroblast is actually the tumor mass consists of cancer cells, but also vascular structures, inflammatory cells, and fibroblasts. And these kind of cells account for up to 90% of the tumor mass. And cancer cells induce the fibroblast activation via the TGF-beta. And these cancer-associated fibroblasts have a supporting function, many functions on the cancer, such as cancer growth and invasion. It can contribute to the remodeling of the extracellular matrix, and it can promote the invasiveness and angiogenesis of the tumor cells. And it can induce epithelial to mesenchymal transition, and it can be involved in the immunological interaction between the tumor and the host. Consequently, it can have an effect in the tumor metastasis, angiogenesis, and also tumor metabolism. And there is a fibroblast activation protein, which is FAP, is a transmembrane cell surface proteinase that degrades proteins of the extracellular matrix and are upregulated in the cancer. And this FAP is actually highly expressed on the cell surface of activated but not quiescent fibroblasts. And in the normal tissue, actually, this FAP is not highly expressed. And this FAP, expression of this FAP increases in remodeling process such as wound healing, inflammation, or fibrosis. So it actually highly expressed when these fibroblasts become activated. And as earlier mentioned, this FAP is highly expressed by cancer-associated fibroblasts. So many different diverse type of tumors express high FAP. So it is known that FAP positive cancers are found in more than 90% of epithelial cancer. So it has a potential of pan-cancer targeting as a pan-cancer targeting agent. So by this kind of concept, the Heidelberg group in Germany has recently developed a quinolone-based FAP inhibitor, which is known to be FAP, with a DOTA chelator and labeled with gallium-68 for the PET imaging agent for tumor imaging. So they have reported this gallium-labeled FAP PET-CT, and it has shown more than in tracer uptake in 28 different kinds of cancer. And the interesting part, as you can see in the image, the only normal organs that are mostly seen in this FAP image is mostly the excretory organs, such as the kidney or bladder. Other normal tissue uptake is significantly lower compared to the tumor itself. So it has a high tumor to background ratio, as you can see. Other than that, there are some other advantages of these FAP-targeted imaging. As stroma volume can be larger than cancer cell itself, stroma-targeted PET imaging may be more sensitive than the glucose metabolic PET imaging for detecting small lesions. And also, it can have an advantage in detecting tumor lesions with low or heterogeneous glucose metabolism, or those located in close vicinity to highly glycotic normal tissues, such as liver and near the urinary tract or in the brain, can be some examples. And also, it is possible to do the early imaging at 10 minutes after injection. And it does not require a fasting. So the preparation of the patient can be easier compared to the FDG imaging. And using this FAP, so there has been also attempt to label it not only with the imaging radioisotope, but with the yttrium, which is therapeutic agent. And without any side effect, it has shown some reduction in pain medication using this yttrium FAP therapies. So it seems to be a promising agent which might be introduced in the near future. So there are some ongoing clinical trials regarding gallium-60, mostly they are gallium-68 labeled FAP PET imaging. And these kind of clinical trial will show whether this FAP-targeted imaging has its effectiveness in multiple pan-tumor imaging. And in the near future, we would need this therapy using the FAP targeting. And what I would like to lastly share was this, that for the lutetium DOTATATE, the first in-human study actually started in 2000. But for the first clinical trial in Korea, actually it takes more than 20 years to apply this in the clinical situation. However, for the lutetium PSMA, first in human study was done 5 years ago, but first clinical trial is now under conduction, and we will start in 2020. So we think lutetium, this FAP therapy we can be a more fast follower. And as seen from the Malaysia, which is the country more faster than the Korea, I think to get some interest in these new kinds of drugs is, I think, the most important part. So thank you very much. And if you have any comments or questions, please freely ask. So I think there has been some question. I think not. So if you have any questions, you can ask.
Dr. So, this is Lee, and I'd like to just ask and convey our previous questions from Indonesian and Bangladesh colleagues. That would you please elaborate a little bit more about the difference between lutetium 177 and actinium-225 for their efficacy and for their possibility to be used with FAP, etc. Please.
So actually, this question was, so when we delivered the session to Indonesia, there was a question about when we apply this alpha particle for the FAP, will it be effective? And yes, it can be, but we should think that the difference between the alpha and beta particle is the transmission range of the energy. So beta has a longer transmission, but the energy itself also is different. According the alpha has a higher. So normally there is a consensus that the lutetium or beta particles can be effective in a tumor with a high tumor burden patient or big tumors. However, there is also some consensus that alpha particle may be more effective in such disseminated small metastatic lesions. And regarding the FAP, actually the FAP is expressed not in the tumor cell itself, but the stroma of the tumor. So when we target the FAP with the alpha particle, actually the energy transmission in some way cannot reach to the tumor cell itself, which may reduce the therapeutic effect. So that kind of consideration should be, that kind of concern should be considered when applying the beta or alpha particle for this ligands. But for now, actually, as I shown that there was a case who had lutetium therapy previously, but had a significant reduction after the actinium therapy. There is some reports of the beneficial effect of alpha particle, but it still needs some validation from future studies. So thank you. Is there any other comments?
Hello,
so yeah, I got a question from Young that for the personalized dosimetry, actually we have now started the clinical trial of phase 1 clinical trial of lutetium DOTATATE, and we are for these clinical trial, we do a dosimetry study for every patient. But not actually, we are doing the dosimetry study, but we are not adjusting the dose according to this data. We are just gathering the dosimetry data right now. And we are not actually doing PSMA right now, but we are planned to start the lutetium PSMA, I think very soon, yeah. Then I would like to ask, in Malaysia, do you do some personalized dosimetry for lutetium or DOTATATE or PSMAs? And do you adjust the doses for the patient?
Hello, Mingso.
Yeah, hello.
Yes, hi. Actually, in Malaysia, yes, we do dosimetry to some patients where we think that those patients who need the dose adjustment, but it will be quite selective because certain patients that we know that they definitely need the treatment, and the lesion is not much that you need to definitely adjust the dosage. So basically the dosage, the dosimetry, what we do is we want to know the tolerable dose to the kidney as well as to the marrow. So this is most only our concern. Yeah. And Ming, so actually I have a question for you.
Yep.
Okay, so for your current study, are you plan to do it to phase 3 clinical trial for your DOTATATE? Are you planning to do that?
So actually, in our institute, we have started the NETO2 trial, and so I would just like to show you some. Okay. So actually, in our status, we have two options for a patient of neuroendocrine tumor patient. We have one which is actually produced in Korea which is called SNU-KB01, and it is under clinical trial, phase 1 clinical trial. And for the Lutathera, the Korean FDA actually recently have approved this drug, and NETO2 trial is started. So we are enrolled in the phase 3 clinical NETO2 trial right now for Lutathera. But this the Korea produced SNU-KB, this is actually in phase 1 trial.
Because I'm asking, as you know, that the NATO1 and the NATO2 trial is basically to the DOTATATE was actually put as considered as a last treatment option, where the patient has gone through multiple treatment as well as have been given with octreotide long therapy. So. I mean, I would like to see that if anyone will do a phase 3 trial where they will put the lutetium Lutathera at the upfront treatment. Because
actually, actually the point I have mentioned is that the NETO2 trial actually is an attempt to see the efficacy as a first-line therapy. The exclusion criteria of the NETO2 is who have got other therapy. So the NETO2, but it is for the indication for NETO2 is actually for high grade. So in the high grade, they want to see whether the PRRT, it will be effective for the first line. So I think the result of NETO2 will introduce this PRRT as a first line therapy. But I think for the grade 1, I think there should be right now, as I know, there is no attempt for lower grade neuroendocrine tumor patient right now to get this PRRT as a first line. But there are some, the problem is that there are some ethical problems because I think it is quite hard to design a proper design to put this PRRT as a first-line drug, and to make that kind of clinical design may be quite hard. That's some concern. But if you, do you do some lutetium DOTATATE therapy as a first-line therapy in your country, or do you apply it to patients who have no other treatment options? Do you attempt to do,
Yeah, basically we will use it after the patients have shown the disease progressions after a long-acting octreotide. Then the PRRT will be one of the options for the patient. Okay, so the problem is when the patient who have failed the first-line octreotide therapy, there are multiple options available. So one option is you can give everolimus, or you can give CAPTEM, and the other one is PRRT. So the issue is which one is the best option? So far, there is still a trial going on, like you say, the complete trial between Lutathera to everolimus, but the problem is now, if you look at these reasons ESMO guideline, the European Society of Medical Oncology, they have actually put CAP-10 in front of a PRRT, where they will suggest the CAP-10 should be given to a patient who have metastatic disease after they fail a long-term, long-acting octreotide, to consider the CAP-10 first before you consider PRRT. So I think there are a lot of a trial that we can do where we will, as far as I know, because we have seen patients who have failed CAP-10 and then subsequently come for PRRT, and they actually responded to PRRT. So I think the PRRT should be put in front compared to the CAP-10. Yeah.
I think really important comment. I think I also agree to broadening the indication is important. And as you may have a lot of experience of this PRRT, I also think that this is has a great effectiveness. So I think it might have, this kind of studies will actually is needed, I think, to broaden the indication and make it as a first-line drug.
Dr. So, there are two questions regarding the chemistry related with the new radiopharmaceutical, the therapeutic one. So, would you please just browse the chatting?
Yes, we are seeing the chat, and so there is about, so for the copy, they use a chelator used as DOTA was used. And for the radio labeling using this DOTA, it needs such as extreme conditions, such as high temperature and low pH. So we actually don't have the experience of the FAP labeling, but I think if Professor Yoon-Sang Lee could have some comments of this question.
I think that chemical structure of the PAPI is somewhat stable. So I think no problem for that high temperature and low pH. So actually, that was firstly labeled with F-18. So, and there's no evidence that the stability of the F-18 labeled PAPI compound. So I think no problem with the gallium or lutetium labeling. Okay.
And actually, for the previous question about the therapeutic use of the Ethereum FAP-P, it was intravenous, a systemic injection was made, and about its substitution for the HCC, I am not sure whether it will have a whether it can replace the TERP, because it has quite because this resin therapy actually can accumulate and may have, it has some, although this FAP can be, if intra-arterially administered, it can have effect, but it is not accumulated like the resin. So I think these two therapy has, I think, different role. So I think the replacement might not be done. But as I mentioned, there are also attempts of using the intra-arterial injection of Lutathera to the neuroendocrine tumor patient with liver metastasis. And for the PRRT trial, what I have shown actually is so actually this SNU-KB is the clinical trial, phase 1 trial we are doing. So we do a multiple 4 times of imaging to see to do the dosimetry. But for the Lutathera, it's not So it's not about the NETO-2 trial, but it's about its usage as as it is just usage after the approval from the Korean FDA, not the clinical trial. So in this, we just do one time. So the purpose is not to do the dosimetry, but to see the distribution and whether there has been an effective uptake in the tumor lesions. And also there is some reason for the quality control. So would there be other questions? So so would the answer be proper for all your questions? Then I think we can end the session and we can start after, I think after 8 minutes, we can see again. Thank you very much. And I would like to, again, announce some advertise to you to do the survey, online survey for this lecture. So if you can provide some comments for us, we can actually update the contents of our workshop. Thank you very much.